Hello, good morning. My name is Atreya Dash, and I'm a urologist at Valley Medical Center, an associate professor of urology at the University of Washington. And today's talk is about prostate cancer screening and use of PSA, but really the question we hope to answer, or help you answer, is it for everyone or just for some? And so let's get started here. So I first wanted to give a public health perspective, and that is this sort of model of disease prevention. And there are different components of disease prevention. The first is primary prevention, and that is preventing exposures or hazards, encouraging reduction in risky behavior like smoking or not wearing a seatbelt, and then immunization or vaccination. Secondary prevention is early detection of a disease and early treatment, especially before that disease becomes symptomatic and clinically apparent. And then there's tertiary prevention, and that is reducing the impacts of an existing disease. And the issue sort of with prostate cancer and how this fits in is that there really is no good primary prevention. There isn't a vaccine for it as of yet, and there isn't a specific diet that reduces someone's risk of prostate cancer. And then on the other side, on the tertiary side, once a patient has metastatic disease or disease that's spread, that disease is essentially incurable. It may take many years before the patient passes away from that disease, but it's not curable. So for prostate cancer, our focus really is on secondary prevention, and that's with screening to identify the disease early. So what are the principles of screening? And I think this is relevant for our talk, and we'll discuss how, through our talk, we hit these bullet points. But the disease itself has to pose a significant health burden. There has to be a preclinical stage that is detectable and prevalent, and that early detection improves outcome with acceptable morbidity, and we'll talk about that quite a bit. And that screening tests are acceptable to the population and are inexpensive and effective. And this is for you to decide at the end of the talk. And then finally, that treatment exists for the detected disease. So we'll go through these bullet points, not necessarily in order, but hit on these because we want to stick to these basic principles of screening. So and how prostate cancer and prostate cancer screening fit into or follow these principles. All right, so let's talk about prostate cancer first of all. Before the PSA era, so in the mid-'80s, the prostate cancer was quite prevalent. There were about 100 new cases per year and 35,000 deaths per year. And when diagnosed, about a quarter of the cases were metastatic. So that's before the PSA era. After PSA, there are about 220,000 new cases per year, and that's perhaps that with the introduction of PSA, we found more cancers, but there was overall, over time, a reduction in death, 24,000 deaths per year, and also a marked reduction in those patients who were diagnosed with advanced disease when they were diagnosed. So down from 25% down only to a few percent. Now, was this due to screening? Well, let's talk about it a little bit here. This shows the prostate cancer deaths over time, and you can see here that with the introduction of PSA screening in the mid-'80s and early '90s, that there was an increase in deaths, and this is likely attributed to the fact that we now have this new test to find cancers, and then there was a cull effect. We identified all those cancers, and now over the next 20 years or so, there's been a reduction in prostate cancer deaths. Now, can we entirely attribute this to screening? Perhaps not. And Dr. Etzioni at the Fred Hutchinson Cancer Center and several of her colleagues have modeled the effects of screening. And here they show two different actual models, one in their same publication put together by a group from the University of Michigan, another one from the Fred Hutch, but essentially these two panels are similar. And this shows what they describe as the reduction in death from prostate cancer due to the effect of screening. And so here you can see that this the black line is the actual observation of the number of deaths due to prostate cancer, and the red arrow points out what Dr. Etzioni and her colleagues attribute to the screening effect. So the reduction in deaths they attribute not entirely just to screening, but some other factors, and this may be something like improved treatments and so forth. All right. And so we can also look at what we call the changing face of prostate cancer. We discussed it a little bit a few slides ago, but how over time, you see the time axis down here at the bottom, describing the stage at which cancer is presented and how this is evolved over time. And early on, before the 1990s, essentially before the implementation of PSA screening, prostate cancer was often diagnosed at advanced stages, but now in the more contemporary era, we're really finding these lower risk prostate cancers and far fewer of the advanced cases. All right. Now this slide really, I think, captures the heart of prostate cancer and the issues related to prostate cancer screening. And let me explain this slide because this really encapsulates the whole issue. And so over here we have this axis, the x-axis, and that is time that a patient is expected to live. So over here is the time. And on the y-axis really is the progression of that person's prostate cancer. And so let's go back to this x-axis for a moment. So this is a person living his life and then going on to potentially die from some other cause. So he goes along with the rest of his life and then dies from another cause. But if a man has prostate cancer, at the same time competing with other causes of death is the prostate cancer. So there may be progression of disease, and that's the cancer growing over time, going up the y-axis, and some patients are going to die from prostate cancer. Now let's look at these black lines. These black lines represent trajectories of different patients with different diseases. So prostate cancers, different prostate cancers, have different natural histories. Just like most diseases, they're not homogeneous. They behave in heterogeneous and different ways. And then the patients who have them also have other health problems and so forth, other competing causes of mortality. So these patients have different cancers and also have different health issues. But before we talk about each of these patients, let's look at something else here. This middle yellow panel represents the opportunity to detect a patient's disease before he becomes symptomatic. So this here along this y-axis shows this time while the disease is growing when we have the opportunity to detect it before he progresses to this point where it's symptomatic. So this is where this yellow panel represents the time when we could detect it with a test such as PSA. All right, so now let's go through these different patients. So look at patient number one. Patient number one has a very aggressive prostate cancer. His cancer is growing very, very rapidly, rapid progression, and over a very short time span of his life, it's progressing. So you can see here, this distance along this axis, very short, but rapid progression up the y-axis to the point that this man dies of prostate cancer. And really right in here, this represents right in here the time frame that we could have detected this cancer before it became symptomatic. So this was a very, very short time span here, right in here, when we could have detected it. And so PSA, only if we were fortunate to have caught it in a time frame this short time frame would we have found his cancer before it spread. So this is a type of cancer potentially that may not benefit from PSA screening simply because it's so aggressive. Let's see the next patient here. Now we have let's look at patient number 2. Patient number 2 is a patient who has a very slow growing prostate cancer. And this man is a healthy man, so he's going along his life many years, and he dies from something else. On the other hand, his prostate cancer was growing very, very slowly, and so this was never bound to kill him. And so the unfortunate part about patient number 2 is that we have this lead time bias period right in here when PSA or some other screening test would allow us to detect his prostate cancer. All this time where we have this test available that we could find his cancer, but then we would find a cancer really that was never bound to hurt him. And so that's really part of the problem with PSA testing, is that right here, patient number 2 has a cancer that never was bound to hurt him, but we have this giant time frame when we're tempted to detect the cancer and then potentially treat it because we have an opportunity to identify it. Patient number 3 is really the patient that potentially would benefit from PSA screening because it looks like, yes, maybe he might die of prostate cancer if his disease progresses over time. So we have this opportunity to detect it right in here. And then patient number 4 is sort of an interesting patient here. This is a patient who's somewhat elderly. He's further along in his overall life course. He has a fairly rapidly growing prostate cancer. You can see this trajectory going straight upward. But he's already elderly. And so really he's getting to the point where he may die from some other cause in spite of his prostate cancer. So this slide points out some of the issues and some of the problems that we face with PSA testing, because it allows us potentially to detect those cancers that were never bound to harm a person. On the other hand, there are those patients that we may still miss in spite of testing. Okay. So these facts led to the U.S. Preventative Services Task Force to issue a recommendation about PSA screening, and their recommendation was a grade D, which is a recommendation against screening, and against screening in all patients, not only elderly patients, but even younger patients. And there have been a variety of criticisms levied against the task force, and let me go through a few of those. But in their analysis, they considered lower quality and immature trials, and we'll go through these trials that were involved. Their analyses were incorrect as they considered overall mortality as their primary outcome, and there are other issues, other potentially important endpoints such as metastatic disease. And they minimized the idea of active surveillance, where potentially, even if we find prostate cancer, that we don't necessarily treat a patient, understanding that the natural history of progression may be very slow. So this idea of active surveillance has really expanded. And then perhaps they've overstated the side effect profile of primary treatment. So let's go through some of these things. Okay, there are definitely harms of screening that we have to talk about. And this table I essentially copied from our American Urology Association guidelines. In our American Urology Association guidelines offer a recommendation for screening, but in patients who are age 50 to 70 and in relatively good health. But here we can see that there are false positives of the PSA test up to 76%. And this means in the proportion of men with a PSA greater than 3 and having no cancer on biopsy. And let me go through this false positive test. These different numbers are based on the data from different studies, but this was tabulated in the white paper from our American Urology Association guidelines. So the point, though, is that depending on how you look at these false positives, it may be as high as 76% or as low as 5.5%. The other problem is there's clearly overdiagnosis. This may be as high as 1/3 to 2/3 of patients. As we sort of described in that panel describing the natural history, there's this issue of lead time, and this is sort of the lead time by which we may find prostate cancers early before they would have become clinically detectable. There are issues with biopsy, minor complications. These are minor issues, some blood in the urine or the stool, so minor complications, but there may be serious complications. And this happens in up to 1% of patients, including urinary tract infection or sepsis. So these are substantial medical complications, although infrequent. But clearly there are some harms of screening. And recent studies have shown that this U.S. Preventative Services Task Force has made an impact, and the primary care providers, such as you out in the audience, really are the ones who are the foot soldiers out there in implementing the screening and have taken to heart these recommendations. And here, this study shows, this is from the American Cancer Society, showing the reduction in incidence of prostate cancer after the U.S. Preventative Services Task Force implemented their recommendation. And you can see here that over time there has been a steady reduction in the incidence of newly diagnosed prostate cancers, even in young men, 50 to 74, and then even in older men, where really, obviously, this makes a big difference. But you could argue perhaps maybe we're missing an opportunity in younger men in finding a prostate cancer that we could act upon that would be meaningful. But we'll talk about this as we go on. So why should we screen for prostate cancer in the first place? And let's talk a little bit more about the disease and the potential problems of the disease itself. And so we go back to these research studies that looked at prostate cancer and compared treatments, and the treatments that were compared in this randomized study that was published, initially quite a few years ago now, and then updated. But this study was performed in Sweden, where men were randomized to treatment with surgery or simple observation. We called watchful waiting. So they were just told to go with the rest of their life and only come back essentially when they developed some symptoms. And so these were men with localized disease and with PSAs that could be fairly high and well or moderately differentiated cancer. And the follow-up, importantly, was long, because as you saw from my previous slides, the natural history of prostate cancer tends to be defined over a long period of time. And so this showed here that the risk of distant metastasis, that means the spread of prostate cancer, was reduced here in those men who underwent surgery versus observation pretty profoundly. And then also in prostate cancer specific mortality, there was also a reduction. And also, interestingly enough, there was a reduction in overall mortality as well. Now let's look at some of these slides, and this here is a comparison of men stratified by their age groups. So the top row here is all patients. Then here in the middle row are men under age 65, and then this bottom row are the men over 65, and the different columns are over here. On the left are the surgery patients, and over on the right are those who were observed. And you can see here that there was, as we described in the previous slide, a reduction in prostate cancer mortality across the board, but really more significantly, a greater reduction in those who are younger, and not as great in those men who are older. So we can identify really perhaps some subsets of patients who would derive greater benefit from treatment. So here, younger men rather than older men. And now, this is a similar slide here, tabulating the survival curves. And here on this top row are all men. And now, in the middle row are the prostate cancer stratified by their risk, or how aggressive they are. So here's the intermediate risk in the middle, and then the bottom are the high-risk patients. And let's go through this now. So this is, again, likelihood of dying of prostate cancer, so a slight reduction here overall, but more profoundly in those men who have an intermediate risk, and less so, interestingly enough, in men with high risk. So maybe those patients who have such bad disease that the surgery is not going to offer them any benefit because their cancer was so bad. So that was one study. Now let's look at an American study called a PIVOT study. This is performed throughout the VA system. And again, men were randomized to either surgery, we call RP, or watchful waiting. And this showed that there was an improvement in survival in all patients, but there were some differences here too. In men who had low-risk disease, surgery did not offer any benefit, but in intermediate risk, it did. And also, there appeared to be a benefit in those men who had higher PSAs, another marker sort of their disease. So there are some patients that we can identify from these studies, subgroups of patients, really those men with intermediate risk disease and who are younger who benefit from treatment. Now let's look at those research studies that assessed screening. And there are essentially three that we'll go through that are important. There was this European study called the European Randomized Study of Screening for Prostate Cancer, and this looked at over 150,000 men with 9 years of follow-up. An American study called a PLCO study that looked at nearly 75,000 men with long-term follow-up. And then sort of a subset of the European trial, but that was a separate cohort and looked at separately itself, of 20,000 men with a even longer term follow-up, 15 years. And all of this follow-up, this long-term follow-up is necessary because we talked about that long, protracted natural history of prostate cancer. So let's go through these studies, because these were the studies that the U.S. Preventative Services Task Force used in their analysis. So the PLCO study, the American study, looked at these men, over 75,000 men, screening with PSA and exam. And one of the issues with this study was this contamination, and that is that the control group, all men in both groups reported PSA testing prior to enrollment in the study. And then of the controls, 52% of them underwent actual screening during the study. So there was this problem with compliance with screening and then compliance with biopsy as well, in that men were supposed to undergo a biopsy during the course of the study to see if they developed prostate cancer, and the compliance was relatively poor. And then the median follow-up, as you'll see, is a little bit shorter in the end than what was intended from the previous slide, and also shorter than you'll see in the other studies. So really this issue, though, of contamination, especially in this control group where men who were on the controls actually underwent PSA testing, and this ended up leading to poor compliance with the screening protocol overall. So including those men who had PSA testing prior to enrollment, and then in the control group testing through the course of the study. So let's go through this, though. So go back here. So if we compare those issues from the PLCO study, compliance with biopsy, follow-up, we look at the European study, a larger group of men, they had their screening at broader intervals. They underwent biopsy at a slightly lower PSA, but importantly, there was a lower contamination rate, a better compliance rate with the biopsy, and in the end, a longer follow-up. So we could say perhaps this is a better study. And if we look at these two studies in their outcomes, we can see the detection rate of prostate cancer. And here, interestingly enough, in that PLCO study, it shows that there was really not a very big difference between screening and control. But here in the European study, there was a reduction in that screening versus control group. And this is the rate at which the prostate cancers were detected. And so here in the European study, that this ended up being a markedly greater rate at which the cancers were diagnosed. Now let's finally look at this third study, this Göteborg study, a city in Sweden. That was the data were incorporated into the European study, but these were analyzed separately. And so this really looked at this important group of men aged 50 to 64. Screening was not done every year. It was done every 2 years, only with PSA, not digital rectal exam, and the biopsy threshold was initially 3 of the PSA and then lowered later. And as I said, these men, this study was designed separately from the European study, but the data were incorporated into that other one. But long follow-up. And let's look at some of the factors here that in the control group, men who were diagnosed with prostate cancer, of those men, up to 12% were diagnosed with advanced disease and 17% with higher risk disease, versus the screening group where 4% were only diagnosed with advanced disease and 8.4% with high-risk disease. So the screening may have allowed us to identify these diseases early and act upon them by this screening program rather than waiting for the clinical manifestation. So that showed a marked reduction. And the other important thing was here, when we look at this, when we sort of distill all of this data from this study, we found, or the authors found rather, that the number needed to screen was 293, and 12 men needed to be treated to reduce 1 prostate cancer death. And so this is really an eye of the beholder. Does this make screening worth it? Really, these numbers. And when you look at this number needed to treat, you could even say, oh, well, 11 men didn't need their prostate cancer treated and potentially would suffer unnecessarily from some of the side effects. So this is important to understand and put in perspective, and for an individual to base a decision on these numbers. The other important thing is this Göteborg Swedish study had a long-term follow-up. As we talked about, it had 15 years follow-up. And this showed that in the men who had screening, this is showing the progression of their prostate cancer, development of prostate cancer, that over time, that in the control group, that these men developed metastatic or died of prostate cancer in this control group, versus men who were in the screening group, that they did better. And this red bar is showing at the 9-year follow-up. That was the timing when the European randomized study was issued. But if you have longer term follow-up, you can see that these survival curves separate actually quite a bit, so that this is accounting for that long natural history of prostate cancer. But also maybe pointing out that the men who benefit the most from screening and intervention of prostate cancer are younger and healthier men. And finally, one other interesting aspect of that American screening study was that when a group of investigators looked at the men in that screening study who had other competing comorbid conditions, that they saw that in those men who had minimal or no other health problems, essentially, that they actually did better in terms of their prostate cancer specific mortality. Fewer of them died of prostate cancer in the screening group. But if you had some other causes of some other health problems, then really these survival curves did not separate out as well. So the point of this really is that I think it points out that we can identify men really who are more likely to benefit from screening and treatment of their prostate cancer. So this gives us an idea that perhaps we should think about tailoring who we do PSA screening, who we treat. And really the groups that we can identify are younger and healthier men, men who have at least intermediate risk disease of their prostate cancer. So if in sum total, looking at all those data, I think we can make those conclusions, and that can lead us to maybe practice better. So then we have that idea. So really, where should we focus our screening efforts if we're going to do screening? Well, there are some other risk factors too that will contribute to prostate cancer. And so those are family history. So if a patient has some other family member, specifically first-degree relatives who have prostate cancer, whether those relatives were diagnosed with their cancer at an earlier age, and also with an increasing number of relatives. So, for example, both the father and brother or brothers. Now, let's look at some of the established screening guidelines. And so, let me show you the American Urology Association guidelines, and these were published in 2013, and there were several statements here. And the panel recommended against PSA screening in men under age 40. The panel did not recommend routine screening in men between ages of 40 to 54 who were at average risk. But for men at higher risk, for example, men who have a family history or who are of African American descent, the decision regarding screening should be individualized. So potentially consider it at a younger age. And then here, this is the important one for statement number 3. The panel strongly recommends shared decision-making for men age 55 to 69 that are considering PSA screening and proceeding based on a man's values and preferences. And this may mean a lot of hard work for both the patient and the doctor in deciding simply whether to do this blood test or not. But it's sort of important to think about what are the implications of the test before doing it. All right. And then I'm going to skip statement number 4, and we'll come back to it. But statement number 5, the panel does not recommend routine PSA screening in men over 70 or any man with life expectancy less than 10 to 15 years. So even he may be younger, but if he has significant health problems, there may be little value gained from PSA testing, especially if you think back of that slide I showed describing the natural histories of different prostate cancers. But conversely, some men who are older than 70 but in great health may benefit from screening. So how should we do screening if we're going to do it? Well, there's the digital rectal exam. There's even progression of symptoms. There's an understanding that men with a family history may have greater risk. And then, of course, the PSA. And if we look at this, most cancers have a normal exam. Most cancers detected now in this contemporary era have no symptoms. And then really only a relative minority of patients that we find with cancer actually have a family history. Most are just unrelated. And then really this boils down to most of the cancers that we find now in this contemporary era are diagnosed based on an elevated PSA. Now the PSA is really not, or the PSA level is not a line drawn in the sand. We used to consider that a PSA level less than 4 was normal, and that really is sort of an arbitrary line. And we'll go through these bullet points down here, that really when a PSA is in that 4 to 10 range, there's a rough rate of 1/4 to 1/3 of patients are going to have a positive biopsy. But that hit rate goes up markedly once the PSA climbs higher than 10, then that positive rate of a biopsy is going to be 2/3 or greater. And so there's a risk of everything in between based on the PSA. And what causes a change in PSA? What are the other factors? Because the PSA is really a sensitive test, but not a specific test. So other factors can cause the PSA to become elevated. So number 1 is BPH. Of course, we talked about prostate cancer, inflammation, even prostatitis, medications, and finasteride or dutasteride. These 2 medications specifically are important to consider because they will cut the PSA in half. And then other causes, recent instrumentation, some trauma, or if the patient had previous treatment that we were not aware of, such as radiation. And with radiation, there can be acute flare of the PSA for us not to be so concerned about immediately. But the point is that there are several factors that can cause a change in PSA, and PSA itself is not necessarily specific for prostate cancer. So some of the considerations when a patient comes in and has a single PSA test that's elevated is not to necessarily get too alarmed and even consider repeating it within a short time frame, really to confirm that it's not a spurious elevation. Now, again, so going through these issues of PSA, that we see that with differing PSA levels, there are different rates at which prostate cancer will be detected. So even with a relatively low PSA, there'll be some rate at which patients have prostate cancer, and that rate simply goes up with a rising PSA. And so that PSA level of 4 was a rather arbitrary threshold where about a quarter of men would be found to have prostate cancer, and of those men, a quarter of them would have high-grade prostate cancer. And in my own practice, and in discussing with other urologists, many of us actually use a tool that's widely available to you called the Prostate Cancer Risk Calculator. If you just type that into Google on your computer, comes up a website, and that takes into account where you can put in a patient's individual risk factors, including an individual's PSA level, his family history, his ethnic background, so forth, and actually individualize a patient's risk or likelihood of finding a prostate cancer if we were to do a biopsy. So I encourage you to look at that website on Google. You can simply type in prostate cancer risk calculator. But again here, other factors will affect that PSA, including the age. As men get older, that reference range for PSA tends to go higher and higher. And this may be simply related to the BPH enlargement with time. So we've gone through some of the issues of PSA testing, some of the guidelines that are out there. We talked a little bit about the harms, but now let's go back to some of the guidelines. And here I wanted to point out statement number 4 from our American Urology Association. And this says, to reduce the harms of screening, a routine screening interval of 2 years or more may be preferred over annual screening. It is expected that these screening intervals of 2 years preserve the majority of the benefits and reduce overdiagnosis and false positives. So this is based on really some of those other data that I showed you. But really, additionally, intervals for rescreening can be individualized by a baseline PSA level. So we can make some considerations. If a man has his first PSA at a relatively younger age, let's say he happened to have it at age 50 or 55, and it happens to be very, very low, we could consider actually broadening the interval. Or if we're more concerned because it's reaching a worrisome level, then we could consider shortening that interval based on that patient individual risk factor. So there is some wiggle room for us to work based on a patient's individual risk factors. And so now I wanted to show one other guideline here, and this is from the National Comprehensive Cancer Network, because it's useful for us to look at what other experts and people recommend, and offer us, the practitioners, me as a urologist and the primary care provider, some sort of framework or background in which to make our decisions. And so the National Comprehensive Cancer Network offers this sort of flow sheet way of really practically doing this screening. So here we have the patient coming into the office, and we can start our discussion of the risks and benefits, and maybe order that first baseline PSA, and we can consider doing a digital rectal exam. And actually, interesting enough, this is not an absolute compulsory requirement of the National Comprehensive Cancer Network guideline, and part of that is because the actual digital rectal exam, quite honestly, offers only little additive benefit over the PSA by itself. But let's look at this next step here. We take a fork in the road. So really, is that patient a younger patient, or is the patient an elderly patient, really, and then perhaps less likely to benefit from screening? So let's just for a second look at these older patients. We could consider doing the PSA testing, but really if that patient's PSA is relatively low and the exam is normal, then really we can broaden our testing intervals, even up to every 4 years. Now, if the PSA is less than 1, so a very low PSA, we can broaden our intervals, individualize it for this patient. If he has an intermediate sort of PSA, then go to every 1 to 2 years. But now here, younger man, PSA greater than 3, or a very worrisome exam, then we can think about then doing a biopsy. So here, this guideline here sort of allows us a framework for individualizing our screening efforts based on patient risk factors. All right, so then we look at that worrisome patient with a PSA greater than 3. Well, we have some choices again. Repeat the PSA, especially if this is his first PSA. He's never had one before. We want to make sure this is not a spurious elevation. If we hadn't done an exam, we can incorporate our physical exam, our digital rectal exam, and then consider, does this patient simply have benign disease, or understand his history better before deciding on doing a biopsy. All right, so in some of those men, yes, we are going to go ahead and proceed with a biopsy, or no, we're going to follow that patient and see what happens. Or, and I'm sorry for now introducing this sort of at the last second, but we can give some consideration to some adjunct testing. And these are some additional tests that are now out there that can further stratify a patient's individual risk. Really widely available is this free PSA. The other one is a recently developed test called the 4K score, or then this other one called the Prostate Health Index. And all of these tests, all three of them, incorporate to some degree or the other what we call isoforms of PSA. So PSA being this enzyme, prostate-specific antigen, but there are different forms of it, or isoforms, and these are incorporated into these different tests, weighted differently and so forth, in these tests to further risk stratify the likelihood we would find a prostate cancer if we were to do a biopsy. So the point, though, is that before we necessarily proceed with a biopsy, there are some considerations. Yes, in some men we're so worried we're going to do a biopsy. In some men we may opt to follow them closely with a repeat test, including exam. And then some men we may incorporate an additional test into our thinking. All right. And so we're getting near the end, but I wanted to point out to you that there are different ways of actually implementing our screening, and these may weigh and offset the potential benefits and harms. And once again, Dr. Etzioni and her colleagues at the Fred Hutchinson Cancer Center have really been at the forefront of this and looking at different ways and offering different policies of screening. And over here, they describe 5 different strategies or policies of PSA screening, and here they go through the different aspects of it down here, the ages at which these would begin, and the intervals between screening, and then the threshold at which that a biopsy would potentially be offered. And down here, it's a little difficult to see, but you can see here that these are the different outcomes, including the number of PSA tests that a person would potentially have in his lifetime, the probability of a false positive PSA test, the likelihood of diagnosing a cancer, and then even diagnosing a cancer that was not clinically significant. And the sizes of these blocks compare across these different policies. And you can see here, the point though is that you can really kind of tailor a policy really to potentially reduce the number of tests. Let's look at policy number 3, reduce the number of tests. Here's a moderate number of PSA tests. But if you look across here, the reduction in the number of false positive tests compared to the other policies, and then here a marked reduction in the likelihood of overdiagnosing an irrelevant prostate cancer. So there are other policies, however, that yes, fine, we'll find more prostate cancers, but also potentially, like for example, policy number 5, here a high detection rate of prostate cancers, but also really the highest rate of detecting clinically irrelevant prostate cancer. So we can, again, tailor our policies or strategies more effectively to achieve our desired goals of maybe finding those cancers that are significant, reducing the number of tests, and reducing the number of false positive tests that lead to unnecessary anxiety, and really diagnosis of cancers that were not harmful. And I'd like to point out too that we've sort of taken these new information to heart, and this chart here shows the implementation of active surveillance over a recent contemporary era in the state of Michigan, and this is showing that, number one, as men get older at the time they're diagnosed with prostate cancer, we're increasingly using this idea of active surveillance, so watching those men rather than treating them, because we know their cancers are slow growing. So in elderly men, an increased rate of observation. In men who have increasing health problems, as measured by this Charlson comorbidity, as they have more frequent development of health problems, a greater number of those patients are having their cancers observed. But on the other side, in those men who have worse cancers, for example, we on their biopsy have multiple pieces indicating cancer, that a smaller percentage of them, as their cancer volume has increased, that fewer of them are undergoing surveillance or observation, and more are going towards treatment. So this idea, though, of surveillance, which I didn't expand upon, is the idea where, because we know that the natural history of prostate cancer may be a very slow progression, that we can take advantage of that. And there's this broad window of opportunity where we can follow that cancer, and if we observe a change, then we can act upon it. So only if there's that change in the cancer indicating it's more aggressive do we act. So that in the men who have no progression, who are doing okay, their cancer is just staying stable, then in those men we don't treat them, continue to follow them. And the rationale for that is to avoid the harms of treatment, so that we can preserve their quality of life while maintaining and working in this window of opportunity of curability. So really, I think we have taken this to heart, and so that as urologists, that the men we do now find with prostate cancer, that we're being a bit more cautious and understanding there are some important, that there are other important aspects, and that's really preservation of quality of life and avoiding the harms and side effects of the treatment. All right, so what are our take-home points? That the PSA screening for prostate cancer has caused a major stage migration of disease, that we do diagnose more cancers and earlier, and this has led to fewer deaths as a consequence. But there are problems with the screening trials, and we know, though, that the longest follow-up studies yielded the greatest benefit, and that there are some provocative sub-analyses that can help us identify patients who are more likely to derive benefit from the idea of screening. And then furthermore, there are clear subgroups of patients who are more likely not only to derive benefit from screening but from treatment itself. And so perhaps this does support this idea of early detection, but also that we have to be cautious and only intervene selectively. And then really weigh this idea of active surveillance in many of our patients before treating them, to avoid some of the harms of treatment. And we need to really improve on our screening, and perhaps in our policy efforts through our American Urology Association or future iterations of the U.S. Preventive Services Task Force, implement smarter screening policies. So these may be less frequent PSA testing, or incorporating an individual patient's risk factors into a calculator, including their other health conditions or their baseline PSA levels and so forth, into our actual individual screening strategies. So thank you for your time.